let's pick up where we left off. We're basically now just continuing right through. We're going to talk about treatment planning. We're going to talk about the clinical procedures involved with treating the patient, and then do more case reviews and a little more thoroughly where we open up before pictures, the model. We'll see a little more of the case review happening now. So here we go. So for treatment planning, the important part is to remember where we started, right? Your treatment planning and obviously you're going to have a treatment plan. You're going to watch this video game of the teeth. Well, your treatment planning should come from your diagnostics. So if your diagnostics included an improper arch form, then you should recognize that, oh, when I watch the development of the tooth movement, I see a proper arch form at the end. You want to take an improper arch form to a proper arch form. When you're playing the video of the teeth, you look at the upper arch. Did it go from a V to a beautiful dome? Did you see it form a nice arch? Then, of course, you will have measured your patient. So you'll know, what is my starting measurement? And then, of course, on the treatment plan, there's a grid. You can put the ruler on there to know what was my starting measurement, and did I expand and upright as needed to achieve a proper arch width of 35 to 39 millimeters between the upper first molars. Because now you have your second diagnostic, and you're expecting to translate your diagnostics into your treatment plan. So the treatment plan is the nice video game of the teeth. You want to see this stuff happen in there so that when you actually treat the patient and you take your pictures at the end, look at that, I solved the arch form, I solved the arch width, I solved the inclination, my patient looks good and has a nice bite. So we're trying to get these things solved, and the last but not least was the buccolingual inclination. If you've made that part of your diagnosis, the back teeth are leaning in, then you should see the back teeth upright in the treatment plan. The model will show you the movement, it will happen in the mouth, and then you will have your before and after photos, much like we looked at those 3 cases where you saw before and after kind of quickly moving. Now we'll go through a little bit bigger cases to have more fun with it. But we do want to upright the posterior teeth until they are vertical. When your lower teeth are leaning in even a little bit, you are now receiving horizontally loaded pressures here. You are in occlusal trauma. Even a little bit gives you occlusal trauma. You don't have to be angled all the way like this. A little bit of inclination is very bad, and the more is the worse occlusion, of course. So you want your lower back teeth fully vertical, and the top should match them. So if your top teeth are leaning like this and you see that V shape in the buccal corridors open and dark, upright those teeth on the bottom, upright the teeth on the top, and next thing you know, you are eliminating the horizontal forces and achieving vertically loaded posterior teeth. You are delivering occlusal trauma to occlusal health. Occlusal trauma to occlusal health. Very simple. Arch form, arch width, and inclination, and you're healing your patient here. So now we're going to build out a little model to give you the relationship of expand, procline, and IPR, the dreaded words, right? Interproximal reduction. We're trying to do a little of that or none of that. And it's happiness. If you could do less of that, you should be happier. If you could do less IPR, your team should be happier about that. And if you could do less IPR, your patient will be happier about that. Your patients are not coming in saying to you, hey, remember that polishing you were doing between my teeth with that axe you had? Can we have more of that? That was so good last time. I couldn't stop thinking about that. I'd love to have more of that. Oh, nobody wants that, so you don't need it. But here's how. Now, I think in your handout, your packet you got there, a notebook, didn't you? You got a notebook. It's blank, isn't it? No, you wrote everything I said down? Okay, I got the right crowd here. You wrote everything. So on the 80th page, since you wrote 79 pages of notes, on page 80 in that notebook, you're going to want to draw this. So if you've ever had that feeling of, geez, I just saw something, I probably should have wrote that down, it's about to happen to you. So you might want to open that book and start to draw something on it, because here it comes. Now, don't draw a whole grid. You don't have to draw a whole grid on your notebook. But I do want you to draw a line and a triangle. You should make this nice and big in your book. Draw yourself a line and a triangle. I've got a grid here because I'm going to use markers here. Now, that triangle I'm drawing, the base of the triangle across there, it says TM. TM is transverse measurement. The line at the bottom of the triangle is the distance between 3 and 14. That is our transverse measurement. And what I'm doing is I'm going to mark off 1 millimeter increments across each side. So basically what we're doing here is you draw a line on the bottom, you draw a triangle off that line. Write TM in the middle like that, and then make these little hash marks going outwards. And just put a little note, 1 millimeter. That interval is going to be 1 millimeter for you. Put your little hash marks, 1 millimeter. This is what you have on your screen. You don't need the whole grid in the background. That's for me. You need the white triangle. The gray lines are basically all you need on your paper. So anything that's in gray, scribble it down. Because now we're going to add to this, and you're going to start to see the relationship between expanding, that's posterior teeth, proclining his front teeth, and IPR will be the last part. Okay. So what I'm going to do with this now that I'm marking 1 millimeter out on my intervals, I'm going to draw a new arch line here. So all of a sudden what's going to happen is we've got this now. In other words, if my transverse measurement increases 1 millimeter on each side, I'm drawing a new arch line here. My red is my new arch form. But let's do that for each of those markings. There's a 2nd millimeter on each side, then a 3rd, then a 4th. So basically I'm just showing you millimeter increments of 3 and 14 moving apart, and a new arch length that's happening every time you move the back teeth wider or farther apart. You've got this new arch length and form happening. So the simple statement is that, well, with every single millimeter I move wider, my arch length is growing. Every single red line is longer than the previous. Okay? Every single red arch is bigger and bigger and bigger. So this is getting longer. Well, obviously, if you have a longer arch to work with, your crowding is going to go away. So we're talking about the teeth at the beginning are our V-shaped arch. The original white triangle in the center is our V-shaped arch, which comes with all this crowded teeth. We've got all these crowded teeth to contend with. How are we going to resolve this? Oh, I feel like I need 0.5 millimeter of IPR in 8 places. You don't. I feel like I have to take a tooth out. You don't. Okay, here we go. So we're moving along these millimeters, and the red lines are getting bigger as we go. I'm getting an increase in arch length. Now, the transverse measurement is linear. That's a line. And every time I move my molars apart, that line is getting longer. So the line is getting longer, but what we're drawing, the arch is getting longer. So we need a linear to a curve relationship. It turns out it's 1 to 0.7. So the linear expansion to arch length increase in a human's mouth happens to be 1 to 0.7. For every 1 millimeter of lateral expansion between the molars, you will gain about 0.7 of a millimeter of room or arch length increase. For every 1 millimeter of expansion laterally, you're gaining an arch length increase of about 0.7 millimeters. So what would 2 millimeters give us? 1.4. 2 millimeters of expansion gives us 1.4 millimeters arch length increase. 3 millimeters, 2.1. 4 millimeters of expansion will give you 2.8 millimeters of arch length increase. 5 millimeters of expansion are going to give you 3.5 millimeters of arch length increase. 6 millimeters of expansion is going to give you 4.2 millimeters of arch length increase. 7 millimeters of expansion will bring you to 4.9 millimeters. 8 millimeters will bring you to 5.6 millimeters of arch length increase. 8 represents what I drew on the board here. 1 on each side going out to 4. 4 and 4 make 8. So I'm filling this in. This happens to be expand or wider only. We haven't done any proclining yet. That's next. Now the next step is we're not just moving the back teeth wider, we are also proclining the front teeth. When your front teeth are crowded, you have something that the teeth are too close to the palate, you need to move them away. Your upper teeth are too condensed, your lower teeth are too far to the tongue, you're moving them wider and forward. So let's go forward a little bit. If we go forward by 1 millimeter, so now you can draw a line going this way, and then you make another arch up to that 1 millimeter. We're only going to go forward 2. We don't go forward very far. The predominance of the movement is in the arch width, but you will need a little bit of procline. Your front teeth are not where they belong in a forward direction, so we got to go forward. There's 1 millimeter, then 2. Well, guess what happens when you linearly, you're proclining 1 millimeter, then 2 millimeters? Well, your arch is a curve. It's line to curve. The relationship is exactly the same, 1 to 0.7. So your linear procline gives you an increase. For every 1 millimeter of linear procline, you get 0.7 increase in the arch. So if we go 2 millimeters, we just gain 1.4 there. So now we've got this set up right here. All of a sudden, we have this little bit of geometry to show us where are we moving these teeth and how far do we need to go to resolve certain issues. Now, here come the questions. Question number 1 is going to be, what would I have to do? I'm going to talk about width only. We're going to ignore procline. We're just going to talk about width only. Think about this. What would I have to do if I opened up a treatment plan? Because you know you're getting treatment plans back that might have IPR in them. You're using a competitor maybe. You open up a treatment plan. You got some IPR. Let's think about IPR. So let's say you open up a treatment plan and you're getting maybe 2 millimeters of IPR total, or 2.5, or 3 millimeters, or 3.5. You know, if you had 0.5 in 6 spots, you'd have 3 millimeters total. If you had 0.5 IPR in 7 spots, you'd have 3.5. So think about what's your average amount of IPR. The last bunch of cases you've treated, what would be the average of the IPR you're doing? Are you doing 2 millimeters of IPR? Are you doing 3 millimeters of IPR? Are you doing 4 millimeters of IPR? Anybody want to volunteer a number on their last chunk of cases, how much IPR they might be doing? A 0.5 in multiple spots? So the total might be 2 to 3? 2 to 3. Yeah, that number usually gets out there, 2 to 3 millimeters. So let's just start with 2. You open up a treatment plan, there's 2 millimeters of IPR, and that 2 millimeters is a total. It could be divided up. It could be 0.5 in 4 spots, right? It could be 0.4 in 5 spots. Now 2 millimeters, it could be 0.3 in 6 spots, which is 1.8 total, then a 0.2 somewhere. You see what I'm getting at? There's IPR spread out, but let's just think about the total. I see 2 millimeters of IPR on my treatment plan. Now the question is, what does it take to get rid of 2 millimeters of IPR? What does it take to get rid of 2 millimeters of IPR? Now, in order to get rid of 2 millimeters of IPR, if we're not going to do the IPR, we're adding the tooth structure back on the screen. So we need more arch length to keep our tooth structure. Instead of cutting 2 millimeters away from the tooth, what would I need to do to gain my tooth structure back, meaning don't do 2 millimeters of IPR? Now, I'm going to make it a little easier. I'm going to say it this way. What do I have to do to get rid of 2.1 millimeters of IPR? Okay? Did I make it easier? Does everybody want to answer now? Because I know, I'm the same way in the audience. I shouldn't say it, I shouldn't say it. I'm going to be wrong like 9 times out of 10. Then everybody knows he's the idiot. So, okay, so if you want to get rid of 2.1 millimeters of IPR, you ready for this? You need 3 millimeters of expansion. 3 millimeters of expansion, but here's the magic trick. That 3 millimeters of expansion is exactly 1.5 on each side. That is all you needed to lose 2.1 millimeters. You just need your back teeth to move 1.5 millimeters each. It's 1 millimeter on the right, 1.5 millimeters on the right, and 1.5 millimeters on the left. You're not doing 3 millimeters of expansion. You're doing 1.5 on each side. And that is the magic trick of losing the IPR. Let's take it a step further. Some people said 2 millimeters of IPR. Some people said 3 millimeters of IPR. What does it take to get rid of 3 millimeters of IPR? Now, that could be 0.5 in 6 sites. 0.5 in 6 sites, that's 3 millimeters total, but what do I need to get rid of 3 millimeters of IPR? Let's make it easy. I want to get rid of 2.8 millimeters of IPR. I just want to get rid of 2.8 millimeters of IPR. What would I do for that? Yeah, it's not 4 millimeters of expansion, it's 2 on each side. Do you know what's happening to your molars when they're leaning like this? Your lower molars that are inclined, do you know how far you have to move them to get them vertical? Do you know how many millimeters this shift is? That's a lot of millimeters to upright your molars. Can you do 2 on each side? If you could do 2 on each side, you just lost 2.8 millimeters, almost 3. What if you happen to have 0.5 millimeters of IPR in 7 sites? You got back your treatment plan, canine to canine. I have 7 choppings of 0.5 in my treatment plan. Uh-oh, 3.5 of IPR, what do I have to do for that? 5. But I'm not doing 5 millimeters of expansion anymore, am I? What am I doing? 2.5 on each side. I just need to shift this molar 2.5 millimeters. Look at your perio probe to remind yourself what 2.5 millimeters is. It's nothing. It's nothing when you're talking about uprighting molars. You can have 2.5 and 2.5 on almost any amount of crowded case you see. You'll easily have this. Wait a second, I just lost 3.5 millimeters of IPR because I just committed to moving my back teeth 2.5 millimeters each way. 2.5 and 2.5, that's 5. You separated the teeth by 5, but it's not exactly 5 millimeters of expansion. It's 2.5 millimeters of uprighting on each side. We only are talking about the back teeth. We haven't even touched proclining the front. Let's get this a little more complicated. I want to get rid of, oh my goodness, it's super crowded. There's a blocked out tooth. I got to extract that tooth. Absolutely not. What's the measurement on a lower incisor? Lower incisor width could be 5 millimeters. A lower incisor width could be 5 millimeters wide. What would it take to get rid of 5 millimeters of IPR? You got a blocked out incisor. You send in a case that has a blocked out incisor. 3 teeth are touching and 1 tooth is behind or in front. Blocked out lower incisor. You know you need 5 millimeters of space for that tooth. Now 5 millimeters of IPR is one thing, but what does it take to get rid of 5 millimeters of IPR? 4, and I could say it 4.9 if you want an easy question. I'll go, what does it take to get rid of 4.9 millimeters of IPR? Oh, 4.9, I can see 7. Now 7 could be 3.5 on each side, right? But we haven't touched procline yet, have we? What if I could procline 1 millimeter? If I procline 1 millimeter, If this case allows me to procline 1 millimeter, I gain 0.7 there. You know what the 4.9 becomes? 4.2. I only need 4.2 in the back. So the 4.2 is 6. I can drop the posterior from 3.5 on each side to 3 on each side if I do 1 in the front. What if you could procline your front teeth 2 millimeters? If I can procline the front 2 millimeters, I get 1.4 millimeters right there. My 4.9 minus the 1.4 brings me to 3.5. 3.5 is only 5 at the back. In other words, 5 at the back is 2.5 on each side. And if I give 2 millimeters up front, I've got 2.5 on each side. That's 5 at the back. 2 at the front is 7. I got to 7. So on the right side of the column, it's what am I doing with expansion of the posterior teeth alone? On the left side, I'm adding in a little bit at the front. You have the benefit of both, the back teeth and the front teeth. You have 3 spots to look at, right side, left side, front. And if you can bring those numbers to add up to the IPR, which now you'll see every case can have that opportunity. You don't need IPR. IPR is not a need, and it has nothing to do with the amount of crowding. There is no correlation to, oh, excessive crowding means more need for IPR. No, the more crowding I have, the more I need IPR? Absolutely not. The more crowding you have, the more tooth movement you need. That's what that is. The more crowding you have, the more tooth movement you need. Where do I get it from? Well, I'm looking at arch form, arch width, and inclination. How do you know how far to move the back teeth now? Well, I'd like my back teeth to be vertical and stop there, but I also know I should be between 35 and 39. Now you have an ending point. You've got half on this side and half on that side. Now I'm at 36. Wonderful. And if you only need 1 or 2 millimeters going forward, you can solve all of your tooth movement without any IPR. And this is the reason I don't have a single bit of IPR in the last 5 years. Not one case yet. 5 years running. And I'm expecting to keep that going. Now, the one category where I'll throw a piece in is going to be the black triangle. When someone smiles and I see a poppy seed, I put 0.1, just like any other normal person. You put 0.1 because you make a little change. It gives you the papilla filled in. That's a nice service. That's an aesthetic. We're talking about losing 0.5s between teeth, okay? That's a technique that is a choice you could do, or you can study this map a little bit and see how easy it is to get rid of IPR. This shows you exactly how little you need to do to reduce your IPR exposure. So now you can take a picture of this. It's going away, but you scribbled it on your pad, so you'll have a photo in your phone, and you'll have a picture to see that, oh, next time you open your treatment plan, you do your math on your treatment plan. So let's say the treatment plan comes back and it has 2.1 millimeters of IPR. You write back and you say, please expand away the IPR. That's an easy way to say it. Please expand away the IPR. And they'll move the teeth a little more and the IPR will disappear, basically giving me my tooth structure back. So that's a simple way to correct that, is just write back, please expand away the IPR. One way you could go about doing this is you could take a baby step, which is send in your cases, you get the treatment plan back, there's some IPR there, you could look at it, then you could send back and say, please expand away the IPR. There's nothing wrong with that. Another way to do it is, after a while, if you feel comfortable, well, I've been doing this now for 10 or 20 cases or a year later, I don't want to take the extra step. Then you submit your cases and you check off the box, no IPR. Because the moment you're comfortable, whether it takes you a case or 10 or 100 or a year to have the light bulb fully go off, then you can actually fill in the form and just check off, yeah, no IPR for me. You can build my first version without it. I'm good without it. You'll get there one day, and that's a nice place to be. This will help you get there. Now, we're about to start doing more treatment with our clinical procedures, so I want to show like 2 quick highlights so we understand how are we able to get all these nice movements. And one of it has to do with the cut. The trim line is unique here. We are using a straight trim line, not a scalloped trim line. And there's a difference between a scalloped and a straight extended trim line. The straight extended trim line has a decrease in flexibility, okay? The scalloped trim line, the aligner is very flexible. Very flexible. It loses its form over the 2 weeks. The straight extended trim line, that straight line around the aligner, keeps it more rigid. If you can keep the aligner more rigid for 2 weeks, it will engage your teeth better and give you better movement and tracking. So we prefer the straight extended trim line because studies show that it's less flexible, it maintains its form over time, and it's more likely to express the tooth movement for you, and you don't have to see, like that top picture shows, the scalloped trim line just not fitting that tooth very well. That's a mess up there. Now, as far as the model goes, we do not block out the gingival embrasure. So we do not block out the gingival embrasure, and now you're looking at that straight extended trim line. Where does our aligner go? It goes into the undercuts. It will go into the buccal and lingual undercuts around every tooth. And the moment you go in and surround into the undercuts of the teeth, what you've done is you have made the tooth an attachment. The entire tooth is an attachment because you're now engaging it in every undercut, top and bottom. So your top and bottom teeth are totally encased in the aligner into their undercuts on the buccal and the lingual into all those gingival embrasures. That aligner is locked on so nicely, and every single tooth is now grabbed as if it is an attachment. When you have a scalloped line and it doesn't go all the way into the undercuts, you have to put a bump on the tooth to engage it. You need attachments with a scalloped trim line. Now, this map shows you what's happening with those aligners. Across the top is the scalloped trim line. This is a very nice research that was done on the different cuts to show which is better. So the scalloped trim line on top has 6 attachments. We're looking at the blue teeth. The blue teeth there have 6 attachments on them. Now, just to the right of that is what's called perpendicular pull-off force. Perpendicular pull-off force, all the fancy words for how much pressure does it take to get my aligner off my teeth with my fingers? What does it take to pull it off? And it turns out with 6 attachments and a scalloped line, the blue section, in blue, 8.86 pounds per square inch. So it takes almost 9 pounds to pull off that aligner with 6 attachments on it. Right below it is the straight extended trim line in green. The straight extended trim line with no attachments takes, in blue, 16 pounds to pull it off, almost double. So a straight extended trim line engaging the undercuts on the buccal and the lingual with no attachments at all takes 16 pounds to pull off. Your scalloped trim line with 6 attachments takes 8 pounds to pull off, 8.8, a doubling. What if you put 6 attachments on the green? If we put 6 attachments on the straight extended trim line, it jumps to 22 pounds to get rid of it. Your patient can hang a 21-pound weight off that and walk around with it. It's impressive at the gym. You know, it's like, I can do this, look what I can do at the gym. Okay, so your straight extended trim line with no attachments has a beautiful amount of pull-off force, so very retentive, excellent grip. But where's the contact? That's the right side. The scalloped trim line, all of a sudden you can see where's the contact on that tooth. It's in the incisal half and very light. Green, light contact, red, significant contact. Scalloped trim line only contacts the incisal half of the tooth predominantly, whereas the straight extended trim line, which is vacuum formed into the embrasures and the undercuts, it contacts that tooth with red from the gingival to the incisal, from the mesial to the distal. That's a big difference. It should be no surprise we experience much better tracking with the straight extended trim line. It outperforms the scalloped trim line in research. So the best possible scenario would be you don't block out the undercuts on the model formation, you use a straight extended trim line, and without attachments you have a doubling of the retention of that aligner. You've got a great ability to move these teeth with few attachments. Okay, so now clinical procedures. What are the clinical procedures involved with delivering and treating a patient with aligners? It's really simple, and we'll go through methodically each step. So we're going to start with the case that, let's say, has everything, because while we might do less attachments, and maybe we'll have a lot of cases without them, there will be some. So we're going to say the case that has some attachments and the case that has a little IPR. So we'll pretend we're treating someone with some black triangles. We want to do a little. So we're going to say we do have attachments and we do have some IPR. This way we're doing a case that has everything in it. The first step would be to place your attachments. So when you're ready to deliver and start your clinical treatment of the case, you're going to have a template to put attachments on. So you will place attachments. You're going to learn a lot more about this in the upcoming lectures because we do have attachments in our protocol. There's nothing wrong with them. We're trying to use them minimally. When you start to compare us to other companies, you will recognize we use them less. So you'll see, yep, a lot less, minimal use. And you'll have an opportunity to use this system. But we're going to teach you more about them. Dr. Brian Gray is going to show you a little more about attachments. Now, if you do place some attachments, your next step will be, okay, if I have to do a little IPR for maybe a black triangle or something I'm incorporating into the case, you'll perform interproximal reduction. So your patient will come in, you will bond on your attachments, and you will perform a little bit of IPR if they need it. IPR is part of a clear aligner technique, and you will have some of it sometimes, maybe restorative cases, comprehensive care, black triangles. There are examples we can throw out there. I try to avoid it at all costs like it's a plague, but it doesn't mean everybody has to be like that. But you may have some. We're going to show you how to utilize that nicely. Now, let's say you have a restorative case. The patient's missing a tooth or they fractured a molar's missing. You got a bridge you want to replace. You got to do a whole comprehensive care. Now, their aligners, we can add a Pontic to the aligner so it looks aesthetically appealing. Let's say they're missing a tooth somewhere. They want to smile. You add your Pontic. You open up the packages, you get out your aligners, and you squirt a little, you can use composite, you could use tooth-colored PVS material, that's tooth-colored. You squirt it right in there, so you have a little colored tooth in there. So now you got a Pontic. You can add that for the case that's a comprehensive care restorative case. Now, insert the first aligners. If you've done a little attachment, you've done a little IPR, you've done your Pontics for the comprehensive case, you put your aligners in there with some instructions. You pop the aligners on, you give some instructions. Well, you're going to wear these all the time except for eating and drinking, except water. You can leave them on for water. So very simple. Your patient's going to wear these all day and night except for eating and drinking. You take them out for that. That means in the morning when you're breakfast, coffee, teas, juices, whatever, then you got some breakfast you're going to eat. You want to have a break, you want to have snacks, you want to have lunch, you want to have chips, you want to have crackers, you're going to dabble all day long. Well, anything you want to do, take it out of your mouth. Take it out, put it in a little travel case, enjoy it, then you put them back in after you're done eating. So we take them out to eat and drink. If you're drinking water, you can leave them in. No problem, nice and easy. Clean them. One way is nice and easy, just take your toothbrush and toothpaste. You brush your teeth twice a day, brush your aligner a little bit, keep it clean. You do need it for 2 weeks. If you don't clean it, it's going to fade a little bit. You might see that it gets a little funky. So if you don't clean it at all, yeah, there's a new one coming in 2 weeks, but that can get a little gross. So try to do a little toothbrush, toothpaste. Can you get tablets and put it in the at-home ultrasonic kits they sell online now? You can do that. You could do all this stuff like this. Take scans. You're going to teach your patient to take a scan, day 1, day 14, then of course follow the instructions. So we have an entire section tomorrow on the monitoring. So we're going to build out in 1 hour tomorrow all of the monitoring steps. So this we won't go into detail here because we have the entire section on monitoring in its own segment. So the scans for the monitoring are going to be built out all alone. But then one of the fun things that you could do right away is to deliver whitening gel. Give your patient some whitening gel. Now you'll notice in the kit when you receive your aligners there is a spray foam, a pump in there that's a cleaner and a whitener. So you can spray that in, you can kind of foam pump that into your aligners, pop it in there. It does a little bit of whitening, it's very mild. It'll keep your aligners clean, comes with the kit. It's a small sample so it kind of wears out quickly, it runs out. But what you want to do at the beginning is deliver whitening gel with some instructions. And the reason we do it at the beginning is you're about to deliver aligners that are going to move your patient's teeth, and you're going to notice the movement in months because you don't see the movement in the first or second aligner because you got to get to at least past 1 millimeter. Patients don't see a millimeter of difference. They start noticing when you get to the second or third. So it takes a few months before they say to you, hey, I see my teeth are changing now. I can see the movement. This is going great. That's a few months. If you do want to take advantage of the instant gratification from your patient, you give them the whitening gel on day 1 because they will see a change in a day or 2, and by 7 days it's dramatic, and by 14 it's unbelievable. So why not have in 14 days' time an incredibly dramatic change from whatever the yellow they had to the B1 or the XL or whatever the white shade you're using. So 7 days later, they're incredibly happy. By day 14, within the first aligner, they have bright white teeth, and they're extremely happy. Takes their mind off the movement because, you know, they want it instant. They're like, I don't see a change yet. I don't see a change yet. I don't see a change yet. It's day 3. It's day 3. Why are you calling us? So we're not supposed to see you for 6 months. How come you're calling us? All right, deliver whitening gel with instructions. I grew up in the Bronx. I'm sorry about that. It slips out every now and then. Slips out every now and then. It's so nice to hear from you. It's lovely. What a beautiful day. Do you want to come over and see us? We would love to see you too. We already have like 80 people here, but why don't you come over too? That's how. There's the Bronx, and then there's appropriate. I'm sorry. All right. All right. So you deliver the whitening gel. What's it look like? This. We show them how to do it. So you could take a picture of this. Now, I won't show them how to put it in every single tooth in their aligner while they're in the office. I show them one tooth. I get out the gel, I take a sample aligner, I don't use their own, I have a sample aligner handy, and I say, let me show you how to put the gel in there. I like to deliver the syringe of the gel. So I don't care what product you use, I'm just going to tell you what I'm using. I don't make any money for this, but I like the Philips Zoom gel. So the Philips Zoom gel is very nice for me. It's like 16% and it's mild. I take it and I show them, watch this. I hold a sample aligner and I squeeze 1 dot into 8 and 9. I'll do 8 and 9. I'll show them. I say, see what I'm trying to do? I just want to put 1 dot in the center of each tooth. And I'll say, what you'll do is you'll put 1 in every tooth tonight when you go to bed. And that's what it looks like when you put 1 in every tooth. You just go around. You hold your aligner, you squirt 1 dot into every tooth right around. You did the top one, you do the bottom one, you put them on, you go to bed. Put them on and go to bed. And 14 days later, this will be amazing. So when you're delivering the whitening gel like this, all you do is tell your patient, I'm using the 16% to go after this because it's very nice for sensitive teeth. We don't have much trouble. We teach the patient, you are welcome to do this every single night. We give them a box which has 3 syringes in it. So the 3 syringes will last a 2 to 3 week run if they do both arches. So 3 syringes, and we tell them, you can do this every single night until it's gone. It'll take 2 to 3 weeks to get through. Your teeth will look amazing. We're going to do another round in the middle of treatment. We're going to do another round at the end. But we want this first round because let's get your teeth light. It's a fantastic look. You're going to love this change. And the only thing you're going to pay attention to is tooth sensitivity. If you use the gel and you notice over 1 or 2 or 3 days, whatever the day is where, hey, my teeth are starting to feel a little sensitive, then you take a night or 2 off from the gel. That's all. You can spread it out. If the patient feels no sensitivity, they're welcome to go 2-3 weeks straight through. Go straight through, use up all the gel, amazing. Let's say you do 3 nights and you notice my teeth are sensitive, then you take a night or 2 off. My teeth calm down, go back to it. You'll have patterns where your patient does 3 nights of gel, then they take a night or 2 off. And then on the rare extreme side of it, you'll have a patient who does 1 night, feels sensitive, they take 2 nights off. Do 1 night of gel, 2 nights off, 1 night of gel. Now to be clear, it doesn't mean taking a night off from wearing your aligner. You wear your aligner every night to bed, right? Because remember you're talking to your patients. So when you say take a night off, that's from the gel only, not the aligner wear. You wear your aligner to bed every night. So sensitive teeth get to pace themselves. We teach the patient very simply, whiten your teeth as you are comfortable. You can set up whatever the pattern is that gives you your comfort. Little sensitivity, time off. Whether it takes them 2 weeks or 4 weeks or 6 weeks, guess what? 6 weeks would be the outside worst it would take to get through the gel. 6 weeks later, your patient is loving what they see. Light, you've solved a problem already. They're very happy. And guess what starts seeing after 6 weeks happens? 8, 10, 12? I see my teeth moving. Now my teeth are starting to get straighter. So you may as well take advantage of the whitening gel early. You can use this from day 1. Set yourself up for success. Happy patient instantly. There's nothing wrong with this technique. It's brilliant for happiness in the patient early, right away. All right, so now let's take a look at this is a very current patient, which is wonderful because it's so recent that we're in the middle, but I'm going to just show you how this can flow through because I'm actually going to jump back in. It's a college student who happens to start getting her wisdom teeth erupting right in the middle of treatment. So we're going to do a first round, then go back in for round 2 to recover the wisdom teeth and get them in line too. So very fun case here. Okay, so Mackenzie comes in and we look like this. Now this is the before. And we're crowded, and this is college age, so we'll say 18 at this time. So college age, this is our before. Now I'm only going to show you this picture to start, because now that you've seen a bunch, we're going to look at this one photo here, and I'm going to ask you, do you have an impression on what the arch form might be? Now keep in mind, you only have 2 choices. It's either, and I will show you the arches later individually, but just from this photo alone, do you think when we see the upper arch alone that it will be a proper arch form or an improper arch form? Thank you, 50-50 shot, and you got it all right. Look at this. We're doing great. We're doing great. Now, arch width, same thing. I'm not showing you any more pictures. That's the only picture you're going to get. But here, now the tiny problem is here. The odds are working against you now. It is not 50-50. Is the patient going to measure between 35 and 39? That's your first choice. The second choice could be they could be above 39. They could be 40 or more. The third choice is they'll be below 35. Now you have 3 choices here, so you only have a 1/3 opportunity to get this right. You had a 50-50 shot the first time. You guessed right. Is she narrow, average, or wide? Narrow. Oh, geez, you got 2 right in a row. Look at this crowd. Okay. Inclination, it happens to be this is the photograph you decide inclination or not. Looking at that photograph, do you have proper buccolingual inclination or not? And you don't. You have posterior teeth leaning in. You can see the bottom teeth leaning in. You can see the top teeth leaning in. That's occlusal trauma all over it, but we're only 18, so we don't have tons of damage. But just imagine this bite as the decades go by. Okay, so we have improper arch form, improper arch width being narrow, and an improper inclination. Now, you ready for this? Here comes a final exam. So far, you're 3 for 3. But this is a weighted test because the first 3 you might have gotten right. But if you get the last question wrong, you still fail because the last question is worth half your grade. So the first 3 questions were half your grade. You have a 50% running right now. You've got 50%, but 65 is passing. Now the last question is worth all the marbles, so don't shout out answers. You might want to collaborate for a while because we don't want to ruin it for the whole group. How much IPR does she need? Take your time. Yeah, 0. You don't need any. Why? You're not treating the front teeth. What are you treating? The arch form, the arch width, and the inclination. You don't need IPR. She doesn't need IPR, nor does anybody else. And yes, I can see that canine, number 22, trapped out of the arch. I see it just the same you do. And I know you're looking at that and going, well, maybe he should show us more pictures. They're coming. But what I just showed to you, which you can do with every single patient going forward, is I can give you your diagnosis off of 1 photo. So can you. You should have an impression of the arch form off that photograph. You'll be right most of the time, right? How about the arch width? Yeah, you'll be right most of the time. The inclination, you have that in this photograph. And then right away you know. From a single photograph, you could make your diagnostics and go into this case. But we'll show you all of them anyway. Here she is with a smile. It's narrow. The lip line is wide, the smile is narrow. And then, of course, as we move into the case, we're going to see here we have a class 1 malocclusion, because every now and then we should look at a canine-molar relationship, and it's nice to see we are class 1 at the start, so we have a class 1. There's that fun canine right there, that's 22. It's even in a little crossbite with number 10 at the tip. Look at that, right? Looks like big trouble. I'm sure when we get to the pictures, we'll need IPR, Dr. Morelia. Okay, here you go. So now we do want to know the transverse measurement. Before we just had a question, is she going to be 35 to 39? Is she going to be above 39 wide, or is she going to be below 35? We all said below, narrow. Turns out you got it right. She's 31. So that line, that distance is 31 millimeters. You can use your Bowley gauge, you can use a cotton roll, I don't care how you get it. If you don't measure it, when you send it in for your treatment plan, guess what? When you open up your treatment plan, there's a grid. You can hit the grid button and put it on the screen and measure it then. So you have a fail-safe, even if you never measured it in the office, you have it on the grid. We're going to open one later to show you what it maps out to be. And there we have our upper arch, narrow at 31, V-shaped, and then you see the lower. And you can see, oh yeah, the canines to canine, very crowded. In fact, just for fun, what if you just extracted number 22 and lined up the incisors? It might even fit. We don't want to take a canine out. Let's take an incisor out. Pop an incisor out of there, we'll line up the rest of the teeth. It could probably work, but take a look at the back teeth, how they're leaning in. So extracting a lower incisor, that's a bad choice going forward. You could do IPR all over that, 0.5 everywhere. You'd probably have to go molar to molar to do 0.5 everywhere to do it. That's option number 2, right? And really, the best option becomes, why don't we just solve the arch form width and inclination and not do any IPR or extracting? And then you can see how quick this will happen. So now the first plan comes back because we got started with her at about 18. And the first plan came back, and you can see on here there's 15. There's 15 aligners. So we're going to put her in those 15 aligners. I'm going to move forward here. There's no IPR. There's no attachments. I sent it to the competitor. So now, the competitor, I sent it to the competitor because I have no IPR and attachments. The competitor gave me 11 attachments. So the competitor had 11 attachments, 5 upper, 5, and 6 lower. So 5 upper, 6 lower. And I did it for kicks. Now, you can do it for fun if you want to see how many molars do I need to attach for a case if I go one way versus the other. So I just did that for fun, but you're welcome to do that. Now, we're going to go through those 15 aligners. Now, 15 aligners is 7 months. We're going to go through those, and amazingly what happens is her wisdom teeth start coming in right near the end of this. So you're going to see, there they are. At the very back, her upper wisdom teeth are kicked in out to the side there. So this is 15 aligners later. We've started to spread this out. So the upper is spreading out. We're getting space at the distal of the small laterals, which we're going to show you eventually some bonding on the laterals and how nice this can look. But now we have a wider arch. So now we have a wider arch. We're separating. We went from 31 to about 34. So now we're moving along. We've got a little space at the laterals. We don't mind. But since her wisdom teeth made it in, guess what we'll do now? Recover those. I'm going to bring them into the arch. So now we'll go back at it. Now, this is just after the first 15. The lower wisdom teeth are just poking. They're just poking in, so they're not there yet. But if your wisdom teeth come into the mouth, you need to have a liner coverage because you don't want them super erupting and being the only thing touching. If your wisdom teeth over-erupt during a year of treatment and they are the only teeth touching, you can't intrude them. You'll have to extract them. I don't want to lose those teeth. I just want to include them in the arch. So now we have the lower. Now the difference, obviously, you can see the molars upright. Look at the premolar uprighting and the spacing in there. The canines separated. And look, the crowding is gone. There's no IPR. This was 15 aligners. This is just 7 months. That is 7 months with no IPR and no attachments, not a single attachment. And look at that number 22, because the question will always come up, what about rotating a canine without an attachment? Well, you're looking at it right there. Is that enough rotation on a canine with no attachments? Right there. So now you can have all of that beautiful movement without a single attachment. But we're not done. This is the anterior picture. Hey, not bad after 15 aligners. We've got a beautiful uprighting of the posterior teeth, right? Well, I know we like to stare at the front teeth, so we'll go to the front teeth first. The deep bite is gone. How about the gingival remodeling? Beautiful. Even 22. Because where 22 was pushed out there in that crossbite, when 22 rotates back to the arch, look at the gum tissue start to climb and even out. It was lower. 22 had the lowest gum line, now it's back and even into the arch. All of that remodeling, no laser, no scalpel, no grafting, nothing happening to these teeth. So nothing happening to the tissue outside of remodeling. So it's changing beautifully. You could see the whitening gel, little whitening gel lighten the color, but the back teeth fully upright. Upright and vertical, very nice. But here, even in this picture, you can see the wisdom tooth sticking into the side. Both sides, there's a hint of it. We want those wisdom teeth. On the right side, we've got a little space at the lateral, no problem. We still have our class 1. On the left side, we have a little space at the lateral. We still have our class 1. But now that her wisdom teeth started to come in, we want them included. So when we get to this point, we're here. But we've only done 15 aligners. Only 15. We're turning 19 years old. The wisdom teeth are coming in. We're going into it for those. We're going to capture those. Now this part will be a little more fun because we're going to open this treatment plan viewer here to show you part 2. Because part 2 happens to be 14 aligners. But now you're going to get to see the wisdom teeth come into the arch form. We intend to keep them, not extract them. So we can recover those wisdom teeth. So it's a surprise in the middle. Go through your 15. Let's get back in there. But we're also going to look for wider. I want wider to accommodate this whole arch. So they're going to bring this model up here. And then once we have that model on the screen, we're going to look at a few different views. And then we'll get to see where we are. Is it up there? Here we go. So the upper arch. So the upper arch, what we're going to do is play it. So we're going to hit the play button and let it ride through. And you'll see the movement that's happening now. Because now that the wisdom teeth are there, I want my first molars wider, and I want my wisdom teeth in line. So we can play that through, and you start to see, hey, that's a little bit wider now. And I've got my wisdom teeth in line. So my next batch is going to be 14 aligners. Now one quick trick is to hit the original tab and then the final tab. So we go original, then final. Original tab will start out the beginning, and then the final is just jumping to the ending. So you should play through it, let it play a couple times, then you click before and after a couple times to see the snap. That's a very nice change. 14 aligners. Now let's go to the lower arch. We're going to see the lower arch next. Now the lower arch, we'll look at the beginning first, and we'll notice we're still a little bit narrow at the beginning. We're going to press play and let it play. If we're making the upper a little wider, well, the lower's got to get a little wider. So if the upper's going to get a little wider, the lower should get a little wider. So you're watching this play a couple of times through. And then the same thing. We're seeing the back teeth get a little wider. And basically, you're going to go original to final, just to do a little snap of the before and after to see the bigger jump. Nice. But let's go back to the upper arch. Now, the upper arch, we're going to take a look at this with the grid. So now we're going to throw the grid on there, and we're going to put that grid in a 5-millimeter box so you can count and see. So now, this is the beginning. At the beginning, we want to count how many millimeters are between 3 and 14. So we've got 5, 10, 15, 20, 25, 30, 1, 2, 3. Maybe we're at 33 or 34 between 3 and 14. This is the beginning of round 2. We did 15 aligners. She started out with 31. We're at 33 or 34. But now that the wisdom teeth are there and I want to go wider, we'll go to the press play or final to get to the ending. Now at the ending, we can count the boxes to see where we are, and we can get from 3 to 14. We've got about a half, so 5, 10, 15, 20, 25, 30. There's a half on each side. This is going to finish right around 39. So that's a very nice number to be at when you're all done, and you've gotten to keep the upper. Now the lowers are poking through. I've gone through 15 aligners. The upper wisdom teeth surprised us. Okay, jump into 14. That's going to be 29. A total count of 29 aligners. That's about 15 months. But in 15 months of time, I'll have every single tooth except the lower, but the lower we're coming in nice and straight. They're in line. So what will probably happen when I get through these aligners is I'll make a retainer and monitor the lower wisdom teeth, because when they get all the way in, I need the retainer to cover them. We're going to maintain 32 teeth for her. So she leaves for the semester with these, and she'll wear them all the way through. So you just got to see what can happen at a college age where, hey, all of a sudden you get a tiny hiccup in the middle. Her top wisdom teeth are popping in. That's not a problem. Take a new scan, reset, and go after more width. That case begins at 31. We'll finish around 39 when we're done. So all of a sudden you can have all of this beautiful uprighting and spread that all out. Her smile's improving. She's moving in the right direction. In the end, you'll have 32 teeth there to show for it. It's a very nice opportunity to use your treatment plan with the grid to see where are you starting, where are you ending. You can see the arch form easy. From V to beautiful dome, easy. The uprighting, you look at this and it goes like that. And then of course in the smile it shows too. So you get to watch all that through. Now we'll take a look at some other patients in varying age groups. So I think we have to close that for me to advance the slides. So we'll shut that one down so I can go back to my slide deck. And then we're going to look at case after case after case, with a couple of fun ones in there. There we go. All right, Lydia's next. So age group 56 years old, nice and young. Wants straighter teeth and a wider smile. So she comes in, and here you have some photographs, and you can see, oh yeah, there we have some crowding. There's a little crowding on top, there's a little crowding on the bottom. She happens to be class 1. We could see that she has a beautiful x-ray with good roots and bones, so fine, there's no problems here to go ahead into treatment. And we recognize, again, arch form. We would measure the arch width. We would look at the inclination. The back teeth are leaning in. The lower are leaning in. The top are leaning in. Her smile photograph has 8 and 9 prominent. Her smile at the top center, 8 and 9 stand out. The rest of her teeth look kind of little. Her lip line is perfect. The empty buccal corridor is there to see. So she's not happy with her smile. She says she wants a wider smile because she feels like she has the buck teeth. Her 2 front teeth are showing too much. What we can see from the occlusal view, well, 7 is tucked behind number 8, and then number 10 is rotated, so you barely see. You see the side of 10. So sure enough, we don't really have a good view of those lateral incisors, and 8 and 9 are kind of wide, so now you've got this smile that she's not happy with. Then we want to develop our plan. This is all of it in one slide for you to see. Now, if we are expanding the back teeth and proclining the front teeth, there's a very simple formula to think about. Back teeth wider, front teeth forward. Back teeth wider, front teeth forward. While I'm watching my video, I tend to look at the upper arch first. So the lower left movie is the upper arch. I want to see that the upper arch has the back teeth getting wider and the front teeth going forward. That's how you get rid of crowding. Back teeth wider, front teeth forward. Now at the front, it might only be 1 or 2 millimeters forward. That's fine. But the back, I've got my maybe 2 or 3 on each side. And all of a sudden, that's going to start to add up. Remember our formula with our little graph that we all drew in our book? Okay, even if I do 2 on one side and 2 on the other side and 1 or 2 up front, I'm up to 5 or 6 millimeters of change. And 5 millimeters times 0.7 or 6 times 0.7, we're creating a lot of room for these teeth. That's why there's no IPR here. So no IPR, no attachments. We're going to let the back teeth go wider and the front teeth go forward. And then, of course, the lower follows it. I go from the upper arch to the lower. I tend to focus on what my diagnosis was. In proper arch form, I'd like to see that narrow V go to a beautiful dome. In proper arch width, you throw the grid on there, you can see the starting number, ending number. She's going to be sub 35 to getting above 35. Nice and easy. Inclination, the middle view shows the back teeth uprighting. We'll see in the photographs, these should be a full vertical view of the back teeth. And sure enough, you've got arch form, width, and inclination covered. You're ready to accept it. And if you don't see those things conquered in here, you write back. That's okay to put the reject tab and write a little note. I would like to develop a wider arch. I noticed that there's some IPR here. Please expand it away. So you have little things you can write to guide a little more expansion. Meanwhile, this patient goes into treatment, and here comes a little taste of the monitoring across the top, which again, tomorrow there's a whole session on it. But the boxes across the top, 1, 2, 3, 4, 5, that's her aligner count. Going across the aligners, if you have a green circle, it was a successful 2 weeks. You move on to the next one. If you get a red square, like at number 7 has a red square. After wearing 7 for 2 weeks, it was not a confirmed accurate scan. The teeth had not responded enough. She wears 7 an extra week to get the good scan. Happened at 9 and 11 as well. 11 had to be worn 2 extra weeks. 11 was a 4-week aligner to achieve the movement. When we got to 15, taking a scan every week, it never said it was perfect. So what we did at 15 was we took a scan, sent it in to make 6 more. So 15 and 6 is a 21 aligner count to solve this case. And then over time, 21, we could count it as 11 months. But if we send for 6 more and it takes 3 weeks to get them, we'll be fair and say, okay, 15 plus 6 is 21, but there's 3 weeks to get new aligners. So let's count it as another month. So 11 plus 1 is 12. We'll say 12 months. This is a 12-month change. Now in 12 months' time, without IPR and without attachments, we have this beautiful arch form and width. But now with this expansion that you've delivered from molar through canine, you have this beautiful arch development, and your molars are wider, your premolars are wider, your canines are wider, and look who fits in. There's a big difference here from 7 to 10. A big difference from 7 to 10. Now you've spread out the natural tooth structure where it belongs. You haven't had to do any IPR. You have a beautiful arch form. You know how that's going to present in her smile? It's going to look good. When 7 to 10 gets spread out, it's going to look very nice because she's collapsed and narrow, and she's showing you 8 and 9 predominantly. We want to see all those front teeth, canine to canine. So now we've got this change 1 year later. The lower is going to follow that. Now by now you probably noticed she happens to have 32 teeth. Every now and then you get a patient who's got all 32. But if you have 32 and your front teeth are crowded, how many teeth do you have to move? All of them. They were all moving in the middle. In the video, when we played the video, every tooth moved a little bit. Every tooth moved a little bit. So with every tooth moving a little bit, we get to this point. So yep, it's nice to look at the front teeth and they're straight. You could see the calculus from the pre-picture, the teeth where they trap the calculus. Look at the red gum line, the irregular gum tissue, and look at the gum tissue now, and the lingual, totally remodeled. Even your lingual gum tissue will totally remodel to full gingival architecture, and now they don't trap as much calculus. But your molars are upright. Check out your molar width. Check out your premolar width. Check out your canine width. You've uprighted all these posterior teeth, and look at that number 17. Number 17 rotated to straighten out. That wisdom tooth number 17 is turned in. The contact point is weird. Look at 17 to 18, the contact point, totally normal. You didn't put attachments on those molars. You just rotated a wisdom tooth with your clear aligners. You got all your wisdom teeth lined up beautifully around the arch, and what will that give you? A beautiful presentation from the anterior. So 1 year later, we have this beautiful occlusion. Posterior teeth upright, beautiful lightening of the teeth with the whitening gel. Remember whitening gel at the beginning? Whitening gel at the beginning. Let's say this is a 12-month case. Because of the monitoring, we don't recall the patient to the office to check. When they come in, it's just on their recall visit. The only time we see the patient is in the hygiene chair. When they're due to come in on their hygiene visit, we take a peek. How you doing? We know the monitoring's going because we're going to see tomorrow it gets put in the portal. And we know they're tracking perfectly along the way, and maybe number 7 they wore an extra week. Oh, number 9 they wore. We see it all. So we know we're going beautifully. 6 months halfway through treatment, they're in the hygiene chair. In the hygiene visit, oh yeah, you know the whitening went well. We did 2 weeks at the beginning. Here's another box. Do another 2 weeks. So we give them another box of the whitening gel to do another touch-up at this point. Then at that hygiene visit, they're going to come back later. Now again, 1 hygiene visit in the middle, we see them at the end. That's why it's 2 visits. It's 2 aligner visits and 1 hygiene check. But the hygiene check is a profitable visit. That's profitable in hygiene. That's not an aligner check visit. It's you're just taking a look at having the whitening gel. So we do a box of whitening gel at the beginning, the middle, and the end. And next thing you know, you've got this nice light effect. And your patient, happy smile. This is not veneers. It's no veneers. There's no veneers, there's no bonding. It's just the whitening gel. 2 weeks at the beginning, 2 weeks in the middle, 2 weeks at the end. And that is priceless for you because guess what they are an addict of now? Whitening gel addict. So you have created the whitening gel addict. So the patient who comes back in your hygiene chair, remember you're the GP, you see them every 6 months in hygiene, right? When you see your patient every 6 months in hygiene, don't they love when you have to take the bite wings? Your hygiene patients come in, oh, today's x-ray day. No, we just had that last time when I was here 6 months ago, right? We did x-rays last time. And you look it up, it was 4 years ago we took the bite wings. It was 4. You've been saying that every time for 4 years. We didn't take the x-rays. It's like we can't even, oh, what happened? So no, we're taking x-rays today. Okay, you could fight them on x-rays at every visit. That's how they resist x-rays, right? You know what's going to happen when they walk in? The door won't even be closed. You got the gel? You got the gel? I'm here for the gel. Yeah, they want the gel. So the gel is now at reception in the cabinet. So we emptied out all those forms that don't make any money, and we put all the gel up there. Because when your patient walks in for their hygiene visit and they say, you got the gel? And we say, yeah, you want 2 or 3. You're not selling 1 box of gel. You say, look, you're in luck today. It's usually on back order. But since we have it today, you want to buy 2 boxes or 3 boxes. It's $50 a box. When you offer 2 to 3 boxes of whitening gel, how many do you think they buy? They buy 3. 2 or 3, they choose 3. So you sell 3 boxes of whitening gel every recall. Now you're doing 100 patients a year and they come in every 6 months to see you. You're selling 3 boxes of whitening gel at $50 a piece for every recall they come in. Do the math on that in your schedule. That's every patient wants that gel, except the ones you do full reconstruction on. If you're going to do all the crowns, it's much harder to sell the gel. Much harder. We're working on that. We're working on that. Next year's symposium, I'll fill you in. How do we pull that off? Happy lady. This is a great case. This one has a surprise ending. Surprise ending. Okay. 18, she's unhappy with her crooked teeth. So we're unhappy with the crooked teeth, and we ask, well, did you happen to have braces? Because if you could look at this and say, wow, if she had braces from like 12 to 13 or 14, you could see 5 years later she might have lost her retainer. So we ask her, she said, no, I never had the braces. Okay, but her teeth bother her. So we're looking at a little bit of crowding. You could see 7, 8, 9, 10, there's a little overlap in the top front teeth, and there's a little more crowding in the lower. From 22 to 27, we got a little more crowding. But remember, we see our anterior crowding, that's a symptom. What do you really have? Improper arch form with an inclination. Take a look at the back teeth, all collapsed in. So the center photograph of the anterior bite, look at the lower posterior teeth collapsed into shadows and the upper angled in. You have full collapse of the posterior teeth here, and you have a mild amount of crowding. The occlusal, the lower occlusal view is crystal clear how the back teeth are leaning in. Even tooth number 20 is leaning in and rotated pretty far. So you have this full posterior collapse. So we know we're going to work on arch form with an inclination, and when we do all that uprighting, this is going to be beautiful. No IPR, no attachments. But I'm going to give you a little bit of a hint about the upper laterals. So it turns out it is more than 50% of the time the upper laterals are not a proper tooth size. So you have a discrepancy in the tooth size at the lateral more than half of the time. So that translates into, if we don't have an IPR technique going on here, and we don't, and we want to unravel all the teeth, more than half of the time I should end up with space at my upper laterals. That's what that means. So I'm either going to develop space at the upper lateral, or to solve the upper spacing, you can do lower reduction, lower IPR. So there's a pathway to account for upper lateral deficiency. A tooth size discrepancy at the upper lateral means you either have to choose between adding to the upper or subtracting from the lower. And it's very easy to subtract from the lower because everybody loves their IPR so much. So chop up the lower teeth to get them out of the way so you can have the top with no space. That's one way to do it. Or you can just teach your patient that we're going to move all your teeth where they belong, and you're going to have a little space next to these two teeth, but we're going to put a little bonding for you at the end. And it's going to look amazing. No one's going to see it. It's going to blend right in, but it'll bring that tooth to the proper width so you have full proportioned balance of your smile and teeth. So I teach my patients that we add to the top. We don't remove from the bottom. So even though I know more than half of my cases will have upper lateral deficiency, I do not do lower IPR to make up the tooth size discrepancy. I add to the top. So what does it mean for me? More than half of the cases get upper composite or veneers for the two laterals. So you have an opportunity now to add to your production. Most of the time they choose the composite. It's very simple, it's inexpensive, you throw a composite in there. And occasionally when you're talking through the consultation, you might have the patient who say, yeah, I see they're very little. Tell me more about the veneers, because you're teaching them bonding, veneers, nothing. Because those are your three choices. Bonding, veneers, or leave that space. I don't cut the bottom teeth. So the patient has an opportunity to choose between bonding, two veneers, or nothing, leave the space. I'm not going to cut the bottom teeth. Now you have a consultation very nicely, and then next thing you know, you have a patient who understands. The hint for you on the screen is that you have a little more, here's a telltale hint that you know you're supposed to have space at your lateral or your lateral is deficient. When you recognize there's a little more lower crowding than upper. If you see just a little more lower crowding than upper, that's a pretty good indication when you unravel these teeth. For my lower teeth to spread out and get straight, my top teeth have to travel a little further than the crowding is. So what you'd like to see is an equal amount of upper and lower crowding means everybody's going to move and there'll be no spaces. But when you have a little less crowding on top than on the bottom, all of a sudden you know, uh-oh, I have to move those bottom teeth a little further, the top teeth a little further, it's going to mean a space. So here comes a little space. Here comes the movement. So again, the treatment plan, upper arch, I want to see the back teeth getting wider, the front teeth going forward. Back teeth wider, front teeth forward. Just like the little grid we drew to avoid IPR, expand and procline. And it does develop a little space at the upper laterals. The lower teeth, back teeth wider, front teeth forward. Back teeth wider, front teeth forward. Very smooth, right? Back teeth wider, front teeth forward. It's very easy, simple formula. Now we're going to move these teeth. So here she is. After doing the aligner set and whitening gel, she's going to come in at the end. Now we do the two visits, right? The start and the finish. Now the patient's going to come back at a hygiene visit we check, then we check at the end. When they come back at the end, we're not scheduling bonding because first of all I have to see that everything is done. Because if it's perfect, she's happy, I'm happy, we're going to put bonding. But if I want to make a few more aligners for some fine tuning, we have them come back to check. Then we're going to have her go home with more whitening gel because we want to do another nice 2 weeks of whitening before scheduling the bonding. So when she comes in, we have the space just like we predicted. We have the wider arch form. We're a beautiful dome shape. The lower teeth perfectly straight. And now the front teeth are nice and straight without IPR and without attachments again. But remember not to just stare at the front teeth. How about the back teeth? Look at the uprighting you got. You upright the back teeth. The molars are wider. The premolars are wider. The canines are wider. On the right side of the screen is where the teeth belong. All you're doing is moving the teeth where they belong. Very nice. Now the anterior view, looking good. From the front view, we don't see the space, but it's there. I'll show you the side view in a second. The before to the after. Really, this view is for the posterior uprighting. Did I get the posterior uprighting right? Are my back teeth now vertical? And here they are, they are. So you got all the uprighting of the back teeth. You're totally vertical back there, and you have that space. The lateral has a space here, and the lateral has a space here. Now you're going to send your patient home and say, hey, we're done moving the teeth. All we want to do now is have you back for that bonding. So now that you did whitening at the beginning and in the middle, Here's another box. Go do 2 more weeks. We set up the hour. You come back in 2 weeks. We put the bonding on those teeth next time. Go home. Keep wearing your aligners all the time. Use the whitening gel at night. What could go wrong? Right? Surprise ending. What could go wrong? What I was supposed to say was, go home, wear the aligners full time, use your whitening gel every night, you come back in 2 weeks, and the last one I forgot to add, it's an 18-year-old, and make good choices. I forgot to say make good choices. So here is my bonding. So the patient returns 2 weeks later. There's only 2 weeks between these 2 photos. Now I put my bonding on. You can see the distal bonding on 7 and 10 there. No more space. But here comes a surprise ending. So she was out of our hands for 2 weeks. So she's out. Are you laughing at my bonding? No. Who's laughing at my composite? Do you see my composite? Has anybody seen any composite on number 7 yet? You don't even notice number 7, do you? You can't even tell how many teeth she has, what teeth she has. Well, number 7 has a very nice distal composite on there. I don't care if you're looking at it or not. I'm telling you, 7 has a very nice distal composite. And you know what also has a very nice distal composite is number 10. Number 10 has a very nice distal composite. And I don't care if you don't want to look at it. So she went and got herself a late... 2 weeks she's away from us. I'm like, what happened? Now, you're in the office. You have no idea this is there because now she's in. You know, you're reclining the chair back. You're getting ready. You put your loops on. You got your mask on. And then you're like, okay. Oh, shit. How am I going to fix a tooth? I got to stare at this for an hour. So you know how hard it is with the loop? It's 3.5 times, just like you wear. 3.5 times, and it's so focused in on the lateral, and I'm trying to look at the other tooth. And I'm trying to look at that ring, because I'm only going to see this for 1 hour, and I can't take my eyes off it. So I have to stare at this for a whole hour. It's the 2 longest bondings I've ever done. So sure enough, just to be clear, my office, we did not install that ring. So that came from somewhere else. Somebody did that. Incredible, right? So this is the before, this is the after. The bonding is there. The teeth are white. I don't know if you can see this change in the shade. Who even knows? The gums are healthy. I did a beautiful ortho case here with the aligners. 2-year follow-up, 2-year follow-up. Little did I know, there are different styles. This is a different one. 2 years later, she comes in to get her teeth cleaned. We're like, what are you doing? It's a different one. We still have arch form with everything's nice. You can change out the shape. These are the round ones. But then we learned, oh yeah, there's also neon, they have colors, they have stripes, they have marble, it looks like, there's a whole stack of these different things. You just unscrew them and put the new ones on. We had no idea. So like, can you come every week, you change them and let us see what you got going on there? I need more photos. But anyway, the before to the 2-year follow-up, still nice and stable. She wears a clear aligner to bed every night. All right, let's have a little more fun. 1 more to go. All right, so Rebecca comes in. This will be comprehensive care. We're gonna have, a lot of breakdown here. This patient's chief complaint, I'm embarrassed to smile, I'm ready to fix my teeth. So there's a lot of trouble in here, but we're going to talk about comprehensive care. So here's what walks in. Now she's a young lady, she's not even 30 years old yet, but this is what we've got in here. And so it's obvious, I see it too, it's not a clear aligner case, yet. Don't forget the word yet. I told you, everybody's a clear aligner case. If you have teeth and a pulse, that's about all you need. So, get to go. Wait, did that slip out? Something slipped out of my mouth by accident. I have to edit that out of the video. So, because it's not correct. It's teeth, pulse, and a wallet. Sorry about that. I missed the last one. It's teeth, pulse, and a wallet. I misspoke there. Now we have 2 things to edit. Give the guys some work to do. Okay, so here we have this, and there's x-rays to go with it. It's a lot of trouble. But the anterior segment is savable, but we do have lots of lower crowding. So immediately you can see what we would do here is, let's get a lot of the fire put out, get some temps. So I'm going to put the upper arch, what I can save, into a temporary. And then, of course, we got some scaling and root planing going, get some hygiene going, get some plaque and calculus, get some oral hygiene instruction going. And then we basically got her in a set of temps to then follow through on what's next, which is, if you want to rebuild a set of crowns across the top teeth, I would love for the bottom teeth to be nice and straight. Because the lower incisors, canine to canine, really premolar to premolar, that's not where it belongs. Premolar to premolar is not where it belongs, and I would love to spread that out. And if I do spread out the lower, it will have an effect on my beautiful, nice restorative work on the top. So this is now ready for clear aligners. So decay removal, temporaries placed, scaling and root planing, plaque and calculus gone, tissue healing. We have an x-ray of the temps in place. You could see we're going to lose number 12 because someone did a root canal and put a 3-foot filling in it. So it's got that poke. It goes through the sinus. It's a sinus drainage system too. So you have a lot of things. You can charge extra for that, I hear, when you do the root canal filling if it drains your sinus as well. So you have to do extra fees on this. I don't know what the code is, but that's later date. So we're going to put her in aligners. So basically, this was the before, and this is after the temps. So the upper temps are in. She's been scaled, root planed, and prepared now for aligners. Now, the aligners are going to be both upper and lower arch. So if I want to spread out those lower teeth, premolar to premolar, the top's going to have to change too. Now, even though I put the temporary in 2 segments, it's in 2 sections, as soon as I build the plan and let the teeth move, I'll know where to go section in the mouth. I'm going to go in there and section my temp from the lingual so I can let those teeth spread out. Because to move premolar to premolar on the bottom, you're going to move premolar to premolar on the top. So we want to spread these teeth out nicely. Both have to move. So when the patient comes to get their aligners, we start to make sections in the temp. So now you can see just coming through the lingual, try to make some sections. It doesn't show that much from the front, but now they can move those. Now here's one quick little tip with you've got temps on here, right? I'm about to go through a good 10 months of the aligners. When I put temporaries in to go into clear aligners, I use permanent cement. I like permanent cement in there, not because I don't want them coming out to re-cement them. You are worried about washout and them not coming loose. So if your temporary cement leaks, then by the time 10 months goes by and you take them off, you've got a new round of decay in there. So permanent cement in your temps, don't worry about it. You can then handle your case afterwards. They might come off for you, they might not, so you cut them off, you make a new set. Don't worry about it, that's easy. It's a big case, you could imagine what you're doing here. You're not worried about if we need an extra temp. So put the permanent cement, totally safe. We're gonna move those teeth, line them up nicely. This is a very rare placement of a lingual bar. I do this once a year maybe. In talking to the patient, she was concerned that she might slip and not wear her retainers very well. It's like, okay, well, we should probably put a permanent retainer behind your teeth because those can relapse and I don't want to lose them at a quick pace. I'm going to put the lingual bar. It's reversible. It just gets bonded with a drop of flowable composite. You can polish it off and polish the enamel and have exactly the teeth back. So I'm not worried about removing it at a later date. If she ever tells me, look, I'm going to wear my clear retainer every night forever now, great, I can take that off for you. But we did have this increase. You can see the premolar expansion, the canine expansion, no IPR. We've lined up the teeth, put the lingual bar. We got a crown there on number 29. 29 has a nice one. But now we're going to get from temps to final. So here we are after the alignment. So we've done upper temps, lower alignment plus the gel. Look what the whitening gel did to her lower teeth. Those are her own lower teeth. Whitening gel, big change. Luckily, the temps I threw in B1. I tend to throw in the temps in a B1 or XL because I know where the whitening gel's going. So even though we put the temps in and then added the aligners with the gel, 2 weeks later, you're all caught up. So I've got nice light temps, I've got my B1 shade, the gum tissue's remodeling nicely, and the patient can start to smile. Now, she hasn't smiled in years, so she has an awkward smile. She's still afraid to show. This is just temps. So she's just got her temps on, she's starting to smile, show her teeth a little more. Before she wouldn't show the teeth. Now she'll show the teeth a little bit. We're making progress. So we're here. Now we have that hopeless number 12, 13, the starting to extract and graft. So the posterior is starting to get extracted and grafted. What we're looking at here are the individual Bruxier aesthetics. So obviously Glidewell, individual Bruxier aesthetics right around the arch. The posterior is being extracted because the next step will be then the Hahn implants. That's what's next. Same thing with the lower. There's a Bruxier on number 29, and the posterior has been extracted and grafted. We're setting up for the implants next. But in the meantime, that's a lot missing from there. So the front view shows us our Bruxier aesthetic crowns, the lower alignment, the whitening gel on the bottom. Those are all her lower front teeth. And now the gum tissue is really nicely remodeled, very healthy gum tissue, beautiful crowns, beautiful smile, everything here, but the posterior is missing. So why don't we make her something flexible while we're waiting? Because grafting takes time. We let the grafting heal a little bit, deliver a flexible partial. This is a Glidewell upper flexible partial, and we'll give her a Glidewell lower flexible partial. It's temporary, but at least now she's got some complement back there to kind of chew a little bit on. So the flexible partials are in place, and the very next step for her is to go through implant placement. And her Hahn implants will be put in, and then gradually we'll have our crown and bridge on that. So this is the point where she's at today. And the next step's going to be her implant placement. But what you did was you took a mouth that was entirely debilitated in every direction, and you managed to restore what you could keep and then lose what you can't. But meanwhile, the clear aligners play a significant role in shaping that arch. because you were able to separate the lower teeth out where they belong, which changes where your upper teeth are, changes your bite and your arch form and width. You have a really nice solution, and the clear aligners are a part of it. So don't discount the clear aligner section of your treatment. It's nice to do the alignment before the final crowns, because once you get those lower teeth and you send in your scans for those crowns here, they're going to be gorgeous. It's going to be nice. Now that does bring us to retention, because when we treat our patients, we get to the ending, you got to wear a clear retainer every night. So we call them Permaform retainers. You can choose 1, 2, 3, or 4 sets. It's a Zendura A. Our aligners are Zendura Flex, so they're built for 2-week intervals to move the teeth, and if you have to wear it a 3rd or 4th, you're fine. But the retention should be stronger. You do want more rigid in your retainer because you'd like to wear it every night for extended periods of time. The Zendura A is a little more rigid. Now, 1, 2, 3, or 4 sets. You can choose what you like. I prefer 4 sets. I like 4 sets because then immediately the patient has the backup when they lose the first one. And so, yeah, they're at home, but it's kind of surprising how something at home can get lost. And they'll call you and say, I've lost my retainer. And if they only have 1, that's a tiny problem because the teeth like to relapse, and if they start shifting, you need to make a few more aligners to catch up. So we like to deliver all 4 and tell them, look, these are really durable. You're going to wear them to bed every night. They should last you at least 1 year each. 1 year each, every night, all set. You got 4 years of coverage, but if you did lose one, you open the second one and wear it. We're not supposed to take too many nights off. We want to wear them through. So I like doing the 4-set thing. If you were going to be going into some significant crown and bridge and implant reconstructive type stuff, you might only make 1 or 2 to juggle between while you're doing your work. And sometimes with crown and bridge and implant reconstructive stuff, you might actually do a quick vacuum form in the office because procedures might be happening within weeks. And you're not trying to purchase aligners that are retainers for a few weeks, then the next one, then the next one. So I make a few in the office along the way to handle the restorative needs. So the retainers, very nicely done, 1 year each, 4 years total given out. I like to include the retainers in their original fee for the case, so they get their first set. They've paid 1 fee, aligners plus retainers. But they know up front that 4 years later you have to buy a set of retainers. So what you've done is you've set up your recurring annuity in the whitening gel and the retainers. And of course the retainers are what you put your gel in, so they come in on their recall visit, they purchase the gel from you, and they do the whitening in the retainer for their touch-ups. The retainers can be made over lingual bars, like you saw this patient. We put a lingual bar to protect her just in case, like she was telling us, I might not wear my retainers very well. I said, okay, we should lock those down. We just put the bar in, then we scan. And when you scan over the bar and send it in, the retainer comes back made over the bar. Simple. If you happen to have a tooth that is lost or broken during the time frame after, because we're treating adults, maybe a root canal tooth goes south in a year or 2. You can put a Pontic right in your retainer. So you tell the patient who calls you and says, you know, remember we did aligners a while back or whatever? Well, I broke a tooth. Oh, come on over, bring your retainers. Then you learn, oh yeah, you did break a tooth. It was a root canal, you've had a crown there, now we're going to need an implant there. Thank you for bringing your retainers, because you run in the back and you squirt the white PVS in there, and then you can just remove the tooth to the gum line, and you put the retainer right in. You have an instant flipper. It takes you 5 minutes to deliver a flipper for a broken tooth. Run over to the periodontist, or if you're doing it, extract, graft, implant, blah, 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 and now they have their retainer for social settings. It's a beautiful thing to wear socially in case they're missing a tooth. Bite ramps, if you go far down the road and you're thinking about bite ramps on your retainer because you want to keep them open more, tongue space, airway, blah, 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 not for today, but bite ramps are optional if you so choose to use them. I think I'm right on time for lunch. Yikes.
Thank you, Dr. Moralia.